Are there alternate routes that you take? Have you crossed scenarios where a patient has not been approved for a biologic, but they needed a biologic? And then what is your approach to kind of, tackling that issue?
So tackling it, I reached out to pharmaceutical reps of the pharmaceutical companies because there's indigent services. There are saving programs where they go, they haven't covered you. Let's give your patient the drug. You've been this for 3 months, and then you try again. And now you've proved to the insurance company we've tried other things. They've gotten free samples. They've gotten better. There is success. Let's get the drug covered, and that works as well.
Yeah, interesting. And when it comes to education and deciding which treatment to go with, what is patient education like? Because, we see some commercials for medication, and I'm always curious, if you see a targeted ad for some biologic or something like that, are people really coming in and asking for a specific biologic? And do you see that often when it comes to things like psoriasis?
Absolutely. Those time slots are well placed,
Yeah.
especially during sporting events. So people come in, I saw this person, they kind of reminded me of me,
Mm-hmm.
and do you think I can get that drug?
Mm-hmm.
But it also is a double-edged sword. I've also had people ask me for a drug they had no reason to get. It's like that doesn't really pertain to you. But those advertisements do work because some people don't even know that there is a treatment for what they have because they've been deterred throughout their life as well, especially in our community. Like, you're fine. There's nothing wrong. You won't die from it. And then everybody else is getting better. They come to see me and I'm like, oh, yeah, we can treat you. Well, I didn't know that.
Mm-hmm.
So that's disheartening to hear sometimes as well.
Hmm. And when it just comes to kind of thinking about severity of disease, which sites like the scalp, face, genitals, nails, hands, feet, things like that automatically upgrade disease severity for you, even when surface area is small? Is that something that happens? And how does that change your choice of therapy?
So palmoplantaris with the palms and sole, especially because they get pustular, even though they're not infectious, they can't really function. So there's a thing in psoriasis called cognirization. You touch, you hurt the area, you'll get new lesions. So there's not one person that I know who can get through a day in their life that doesn't use their hands or walking in their shoes. So it gets debilitating, affects economic lifestyle. So yeah, even though those are small areas, they're tough areas. The scalp is hard to change too. You're trying to go to work. Let's talk about people with high profile jobs. You're going to need something, even if it's not all over the body. The scalp needs to be treated. Genital areas are equally as important, and it does happen. And it's not areas you can say, let's throw them into a light box because you want to make sure, like with us, we don't have further discoloration of other parts of the body or, light exposure in genital areas. You worry about skin cancer later on.
Hmm. And what is the world of phototherapy like these days for things like psoriasis? Because, things like red light therapy are hitting the market. So,
They
what are
are.
your thoughts on that? And do any of those cross over into the world of psoriasis, or is phototherapy for psoriasis
So
completely different?
phototherapy like UVA, UVB, especially narrow banded UVB, still is predominant. It still works really well, especially for people who don't want to do biologics.
Mm-hmm.
I think it works really well. You just got to be careful how you do it and how much exposure is given to people. I always tell people, especially if you're suffering from hair loss, cover your head if especially not involved because you don't want burning on the scalp or you don't burning anywhere else.
Mm-hmm. How do you screen efficiently for things like psoriatic arthritis and key comorbidities during standard visits? And when should a dermatologist not wait, i.e., let's say immediately escalate or refer?
So it's all about your history. So you come in and you don't ask somebody if they have associated arthritic problems or joint problems, and they would never say it to you. So that's something that needs to be part of your history and physical. And even you can see it in an exam. You should be looking, especially since the skin distribution for psoriasis is symmetrical. Psoriasis or psoriatic arthritis is not, it's asymmetrical. One large joint can be affected. The sausage fingers, because they look like they come on the knuckles and they look like little
Mm-hmm.
sausages. So those are things you should be doing on your physical exam as well, because you want to stop it before it becomes debilitating for that patient. And not every biologic addresses psoriatic arthritis as well. So people are looking for one thing. Sometimes, I've had people come back in. I didn't see it on an exam, but they'll be like, wow, my joints feel better. I'm like, wow, that worked out. So going for a biologic that also takes care of the arthritis also helps as well.